And then we look at cholecystitis. Yeah, of course, you can have acute cholecystitis, and here we have chronic cholecystitis. Obviously, the name suggests cholecystitis is basically inflammation of the gallbladder from many causes, including infection. So you can have acute, but most of the time we end up with chronic cholecystitis. So usually to the gallstones. When you talk of gallstone, you're talking of cholelithiasis. So if you hear of cholelithiasis, you remember your concern, and we're talking of gallstones. That is basically those stones within the gallbladder. So most of the time when there are gallstones within the bladder, it causes irritation of the wall, and you end up with chronic cholecystitis. So most of them will be resulting from gallstones in the gallbladder, the gallbladder. Can also, and these gallstones, of course, can be cholesterol. There are different types. Some which are cholesterol, mainly made of cholesterol. There are some which are pigmented stones, or they can be mixed. That is, a stone has both cholesterol and pigment. And of course, we are looking at the wall of the gallbladder. So there will be chronic scarring. The muscle that will be smooth muscle. There will be hypertrophy of the muscle. The sinuses, we call them Rokitansky-Askov sinuses within the wall. Here we are looking at the wall. And of course, some of the symptoms, somebody will come with complaining of probably abdominal pain. Yeah, that most of the time will be associated with taking of food. Because you remember when you take food, most of the time the gallbladder will try to contract to push out probably the bile. But in this case, in chronic scenario, chronic, there will be low-grade chronic inflammation. And if you are to take the wall and examine the wall of the gallbladder, you'll see infiltrate of lymphocytes, plasma cells, and macrophage cells in the submucosal layer. Remember the mucosa, submucosa, and then you have the serosa. So in this case, in the submucosal layer, you're likely to see the infiltrates of lymphocytes, plasma cells, and macrophages. So Rokitansky-Askov sinuses are irregular gland-like mucosal pockets that extend deep into and beyond the thickened muscle layer. So it goes all the way through the thickened muscle layer. So that's the one we call Rokitansky-Askov sinuses. Outside the muscle layer, there is fibrosis and mild chronic inflammation beneath the serosa. So beneath the serosa, remember there is the mucosa, submucosa, muscle layer, and you have the serosa. So if you're to look at under the microscope, the key histological feature would be subserosal and muscular layer fibrosis, mononuclear inflammatory infiltrates, so there will be those inflammatory cells, and then the Rokitansky-Askov sinuses that we've already talked about. Yeah, the diagram on the left is the diagram of a gallbladder. On the right is a picture of actually a gallbladder with gallstone. You can see the cholesterol gallstone there in the picture. You can see the wall is thickened. The wall of the gallbladder will be thickened. And of course, you can see from the diagram, the wall, the thickened wall, you can see the gallstones within the gallbladder, resulting in chronic cholecystitis. So, of course, cholecystitis is quite a common condition that most of them you will have to do. One of the treatment will be cholecystectomy. That is, you remove the gallbladder together with the stones that are within it. You don't try to remove the stones. You remove the entire gallbladder. Of course, you can see from the neck, we have a micrograph on the right, and then we have a diagram on the left, just showing the main thing that we've already talked about. Hypertrophied muscular layer, that is the muscle hypertrophy. Those Askov, Rokitansky sinuses, mononuclear infiltrate, those are the inflammatory cells like lymphocytes and others, macrophages among others. Then perimuscular fibrosis, that is around the muscles, and beneath the serosa, you have fibrosis. Then when you talk about cholelithiasis, as I've already talked, you're talking about gallstones. Yeah. So when you look at bile, the constituents of bile, in bile we have bile salts, we have phospholipids, and we have cholesterol. That is what those are the major constituents of bile. Of course, there will be water. Yeah. So gallstones are made from constituents of bile. So you can have gallstones that are primarily made of bile salts. You can have some that are made of mainly phospholipid. We have some that are made of just cholesterol, but most of the time they tend to be mixed. There will be cholesterol and all that within it. Um, so most of these gallstones, they're usually formed in the gallbladder, but some of course can be formed even within the common bile duct, but rarely. Most of the time, the stone that is in the common bile duct came from the gallbladder, as in it was able to pass through the cystic duct into the common bile duct. So most of them would be formed within the gallbladder. Of course, we have different types. Talk of cholesterol stones, around 10%, pure pigment, solar bile salts, made of bile salts, mostly around 10%. 80% of them will be mixed. That is, they'll have a bit of bile salt, phospholipids, and then cholesterol in it. And some of the clinical features, that is what somebody will come complaining about, will be biliary colic. Biliary colic is, there will be pain that is intermittent. That is, pain come, then it is relieved. Because most of the time, it's obstruction of the stone within the cystic duct. And so whenever you are taking some food, usually the gallbladder will tend to contract to try and push out the bile. And as a result, the stone is likely to be lodged within the cystic duct and blocks. And so you have that. That's what we call biliary colic. Colic is pain. If you talk also of colic, you're referring almost to pain within the large intestine. That's why we talk of colic. But this biliary is caused because of the blockage of the cystic duct by a gallstone. Of course, we are likely to develop acute cholecystitis and even chronic cholecystitis, as we have said. So these are some of the risk factors for somebody to develop gallstones within the gallbladder. That's gallstone. There is something we call 4Fs: fat. So somebody who is obese, who is fat, who are, so to speak, amekula vitu yake. Female, so it may tend to be more common in female for one reason or the other. Fertile, so it tends to be females, especially in their childbearing age. Yeah, so multipara. Multipara means many children. We talk of nulipara is somebody who has no children. So I know you will be able to look at this when you talk about, when you go to obstetric gynecology, you will talk about parity. Yeah, you can talk of a mother having para 1 plus 0, and you will know what those ones mean. So a mother who is in childbearing age and who has children, those are the people who tend to be at risk. Of course, this one just helps us to remember a few easily. You talk of just 4Fs, but the others, 40, yeah, especially cholesterol stones. 40, so around that age, childbearing age to the 40s, early 40s. So 40. And of course, one of the other risk factors is birth control pills. So people who uses pills, daily pills for birth control, the contraceptive pills, usually it has hormones in it. So it is not that it tends to increase the risk of somebody developing gallstones. Also obesity, as we have said, so we're talking about fat, yeah, increases the risk of developing gallstones. Of course, in medicine, there is never something like invariably, because it can still occur in people even who doesn't fall within this category. It can still occur in males, and it occurs in males, and we've seen males with gallstones. So incidence increases above the age of 40 years, but most of the time it tends to present around 50s and 60s. But of course, we've seen people much younger who have these gallstones. So it tends to be more in female to male ratio 2:1. So for every 2 females with gallstones, there will be 1 male with gallstone. That is the average. And of course, you can have complications of gallstones, including cholecystitis, can lead to inflammation, can lead to choledocholithiasis. Choledocholithiasis will mean choledocholithiasis is gallstones within the common bile duct. That's what we mean by choledocholithiasis. Mucocele. So you can have mucus forming within the gallbladder and actually filling the gallbladder. Mucus forming within them. That's what we call a mucocele. You can have biliary fistula. You can have the gallstone can erode the wall of the gallbladder and actually can cause it to connect. Remember, one of the relations of the gallbladder will be as a transverse colon. So it can even erode from the gallbladder um, into the transverse colon. And so you have a connection between the gallbladder and the transverse. That's what we mean by fistula, biliary fistula. Basically, a fistula is an abnormal connection between two epithelial surfaces. We can also have what we call gallstone ileus as a complication. Gallstone ileus is basically if a gallstone, a big gallstone, were to get into the jejunum, for example, it will go all the way to the ileocecal junction. That is the junction between the ileum and cecum, and it's likely to lodge there. And that in itself can cause obstruction in the small intestine. And so you end up with ileus. Ileus basically is paralysis. So that's what we call gallstone ileus. And of course, they can also lead to gallbladder cancer. So although it's a small risk, this cholelithiasis can lead to cancer, but a very small risk. Bile containing excess cholesterol relative to bile salts and lecithin is predisposed to gallstone formation. So if you have bile that contain excess of cholesterol relative to bile salts and lecithin, this is the one that is likely to form gallstones. And of course, the diagnosis, you can do a blood test if you suspect infection. Full FBC is full blood count, that is basically full hemogram. LFT is liver function test, abdominal ultrasound, HIDA scan. These are some of the things that you can do. And your CSWL is extracorporeal shock wave lithotripsy. So this one, you use shock wave from outside to basically direct it to the gallbladder to hit those stones and try to shatter them. So that is basically, we rarely use in, of course, developed countries, they have all these modes that they can do what they call extracorporeal shock wave lithotripsy, ECSWL. Rarely used in Kenya, and probably in developed countries you have site where you just maybe direct it with an ultrasound or something, and then you focus it, those waves, you focus it on the gallbladder to be able to, try to destroy, make those as they break the gallstone into smaller pieces that can now come out with the bile. That's basically what we mean by that, ECSWL. Of course, there we can see just a diagram showing the gallstone in the gallbladder. Most of the time, they tend to be asymptomatic when it is within the gallbladder. But of course, when it gets impacted in the cystic duct, it causes acute cholecystitis, that is inflammation, and you may have pain. But usually there will be no jaundice. Because you remember, the bile will still be able to get from the liver all the way to the duodenum. But of course, if you have a gallstone that is impacted in the common bile duct, it will also cause acute cholecystitis, and is likely to cause jaundice because now bile will not be able to go all the way to the intestine. And this accumulated bile there will be able to accumulate in the blood, and you end up with jaundice. So basically, those are some of the things that if you have gallstones within the gallbladder itself, within the cystic duct, and within the common bile duct, what are some of the things that are likely to happen? And then, of course, you can have gallbladder carcinoma, which is uncommon, and mostly it will be in the elderly. Usually tend to originate from the surface intestinal metaplasia and dysplasia. So there will be change of the epithelium of the gallbladder to become that of the intestine. That's what we mean by intestinal metaplasia. And then dysplasia, we know what it means. And from there, of course, if it is not controlled, it moves on to become malignant. So they tend to present late, often with liver infiltration. So it tends to present very late. And by the time it is discovered, most of the time, it would have infiltrated into the liver. And usually more in females than males. You see 4 to 1. And the incidence tend to occur late in the 7th decade. And these are some of the risk factors, including cholelithiasis, cholecystitis, carcinogens such as pesticides, genetic factors, inflammatory bowel disease, IBDs, inflammatory bowel disease like ulcerative colitis, Crohn's disease, which we did last time, we mentioned last time in GIT. So it can be infiltrating or truncating. That infiltrating basically is infiltrating all over the wall of the gallbladder or even into the liver. And truncating is growing into the lumen of the gallbladder. That's what we mean by truncating. Most of them will be adenocarcinomas. Remember, adenocarcinomas will be, of course, from the epithelium, mainly of glandular epithelium. 90% of them will be adenocarcinomas. Around 5% of them will be squamous cell carcinomas. And then we have a few that we go for combination of the two, adenosquamous carcinoma. Of course, you can imagine squamous carcinoma will probably be because of metaplasia of the epithelium of the gallbladder. And when you look at these cancers, mostly in 70% of them, you will find gallstones. So most of the time, of course, these are specimens after cholecystectomy, and then you go examine by pathologists. In 70% of the cases, you will find there is gallstones within it. And of course, the way they can spread directly into the liver tissues. They can spread into HeLa lymph node, that is the lymph nodes around the liver. Or it can, of course, get into the blood and they are spread through the blood. Then cholangiocarcinoma. So this one mostly arises in the intrahepatic or extrahepatic bile duct. So this one occurs in the bile duct. So cholangiocarcinoma, I know, is a carcinoma of the bile duct, which can be either intrahepatic, those are the bile ducts within the liver substance itself, or those extrahepatic bile ducts like the common hepatic duct, common bile duct, and so on. And usually this one causes intense fibrous stromal reaction. We call it desmoplastic stroma. So it's mainly the stroma that causes fibrosis. So mostly this one causes fibrosis. So, and they tend to occur early. They tend to cause early obstructive jaundice. So you can imagine if there is fibrosis in a tubular structure, then it tends to narrow, sometimes completely closing the bile ducts. And so you end up with what we call obstructive jaundice. So glandular or duct-like formation. So if you are to look under the microscope, they are likely to form gland-like or duct-like tissues. Yeah. And of course, like any cancer, you are likely to have cellular atypia. So cells are atypical. They are not typical cells. They don't look like the typical cells of the bile ducts. And they tend to have infiltrative growth patterns. So it tends to infiltrate into the wall of the ducts. Yeah. But also they can spread through the perineural is around the nerves, and also through the lymphatic, invading into the lymphatics and spreading by that way.